The stage is yours. Thank you.
Thank you, Dr. Vishal. A very good afternoon, everyone. And first, thank you to the organizers. Dr. Lakshmi, gracious as always, much thanks. We go on to the debate now. So the topic today, as mentioned by Dr. Vishal, extraperitoneal repair does not provide extra benefit. I'm Dr. Vandana Soni, and I'll be speaking for the motion. I'll start with a quick story. So there was this island which had a large, vast grassland and a large forest. And the inhabitant plowed the grassland, used resources from the forest. One day somebody suggested that maybe we should clear the forest because the land out there was more fertile, likely to yield a better harvest. And that is precisely what was done. And of course the harvest was good, but the forest resources were lost. The land became less fertile over time, soil erosion set in, rain patterns changed, air quality changed, the forest dwellers lost their home. So can we say, was it really, truly worth it? Or is there a better way? Could we have gone around it in a better, more strategical approach? So, my esteemed judges, my fellow co-debater, and my dear colleagues, I truly believe that the extraperitoneal mesh repair has no added advantage. Of course, we really do not know how it can be positioned in the armamentarium, but it does not carry any extra advantage over the existing minimal access repairs. And in my argument, I'm going to focus on lack of evidence supporting superiority and the increased complexity and potential complications of the extraperitoneal approach. Now, before that, just a quick word about ventral hernia. Ventral hernia is a common surgical procedure. More than 3 lakh procedures performed annually in US alone. And 75% of these procedures are primary hernias. And a word about the mundane and banal IPOM repair, which has been in existence for the past 3 decades, has fared us very well, is accepted to have superiority over the open approach, has a short learning curve, reproducible, effective, has all advantages of minimal access with decreased surgical site occurrences. However, like any surgical approach, even the laparoscopic ventral hernia approach does have disadvantages. There may be chances of inadvertent enterotomy. There may be bulging due to seromas. Now, there may be a risk of port site hernias, increased postoperative pain has been reported, and bowel adhesions, mesh erosion. However, with the advent of IPOM+, the problem of with the facial closure of the facial defect, it has resulted in better functional and cosmetic results, decreased bulging, and with the advent of introduction of robotic, which is ergonomically superior, avoiding tags and transfacial sutures, there has been an overall decrease in the postoperative pain. However, bowel adhesions and mesh erosions, although anecdotal and rare, still are cited as the reasons why the mesh should be moved out into the extraperitoneal space. Now, the extraperitoneal space is the new playground for the ventral hernia surgeons. The strongest argument being that they want to take the mesh away from the viscera. Other purported benefits include cost effectivity, better tolerance, and lower postoperative pain. However, it does have its disadvantages, has a steep learning curve, technically challenging, has a longer operative time, requires a wider dissection, and has increased related complications. So what does the evidence say? So this is the first systematic review and meta-analysis, which was published in January 2022, just 4 years after the procedure was first described in 2018. And this compared 13 observational studies comprising of 918 patients. They found that the ETEP had a longer operative time. The complications, recurrences, conversions were similar to that seen in the IPOM. However, what was seen was that there was an increased incidence of excessive tissue dissection, including the transversus abdominis release, in nearly 12.7% of patients, including primary hernia repairs, and a need for advanced laparoscopic skills and a thorough knowledge of anatomy. So they concluded that probably this required a further specialization and a move towards specializing hernia repairs, which of course is not practical at all. The second systematic review and meta-analysis was published same year 2022 in April. This was in the Journal of Hernia, and this comprised of 11 studies. Again, they were observational studies, but a larger number of patients, more than 2,000. And what they saw was that all complications associated whether intraperitoneal or extraperitoneal, there was no significant difference. So they concluded that the mesh location really did not matter. Location of the mesh was not associated with any decrease in the incidence of complication, and the location of the mesh should be based on the current evidence, surgical experience, the center, and individualized to each patient. There were at least two randomized controlled trials, one from the US, this is multicentric, comprising of 100 patients. There were 5 robotic surgeons. It was a comparison between robotic IPOM and robotic TEP. And what they found was that there was no difference in the postoperative pain, primarily because in the robotic IPOM, the mesh fixation was also done using suturing, avoiding transfacial and partial thickness tags. They also realized that the overall surgeon workload, the surgical site occurrences, and the operative time favored the robotic IPOM. This randomized controlled trial is from our own institute, AIMS. They, of course, did find some favor for the ETP in the early postoperative pain and earlier return to activities in small and medium-sized effect. Again, the keyword here is small and medium-sized. They also mentioned about cost effectivity. However, operative time, readmissions, and re-explorations were much higher in the ETP. The overall quality of life and long-term pain after 3 months was similar in the two groups. Now, as far as cost effectivity is concerned, being a public healthcare institution, one really cannot depend upon their recommendation, because a patient requiring re-exploration and readmission being managed is likely to incur high healthcare costs, especially when being done privately. Now, this is the most interesting study that I found. This is in this year, May 2023, with one of the authors being the architect of the procedure, which is in question, which is being discussed. They reviewed 24 studies of the overall pitfalls and complications of the enhanced view extraperitoneal repair, and they found that the unique pitfalls and complications included retromuscular hematomas, seromas, access-related complications such as failure to access the retrorectus space, rupture of the rectus abdominis, the linea alba, the linea semiluranis, posterior rectus sheath dehiscence, linea alba dehiscence, complete blowout, and hollow viscous injury. Now, the common thing amongst all these are that they can be very grave and serious, disastrous, and all acute surgical emergencies requiring a surgical intervention. So they concluded that more studies were required, and they could really not recommend where exactly the ETP fitted into the armamentarium of the abdominal wall surgeons. I'd like to conclude my argument with this letter to the editor by Hakan Gok. This was in July, hernia 2023. And these concerns mirror what I would like to also express, that the studies so far presented are small cohorts with an inadequate sample size. There is a short follow-up period with an inherent bias. Excessive dissection is required to create the mandated space and absolute overkill. And there's always a potential risk of injury to the sac due to blind handling. There's an increased use of transversus abdominis release for a tensionless approximation of posterior rectus sheath. So aiming or thinking that the extraperitonealization of the mesh is going to solve the problems is not my idea of the way forward. I think we need to rethink, reassess, and reorient ourselves to the approach. Thank you.
Yeah, thank you.